All right, hello, and welcome again to another Down Fracture podcast, a podcast for talking jaws. Um, your co-host, per usual, Dr. Michael Wasson of Arizona Jaw Surgery with Dr. Sam Bobek of Seattle Jaw Surgery. Sam, we're doing a different day. Did you miss me?
Yeah, absolutely. You were vacationing in what I consider to be the southern part of America. You consider what, like it's north from you?
It's
Where
kind
it's
of
just
lateral, maybe
direct
even south.
west?
Definitely west. In Southern California. Yeah, did the Dodgers game, did Legoland. I got up to
Yeah.
the beach a little bit. It was nice. I gotta say, I don't, this is not a political statement, but man, California, you guys gotta get something to get these slow drivers out of the left lane. Like it's insane. Especially it's like a Prius. It's like they have a point to make that, yeah, I'm in a Prius, but I can be in the left lane. It's like get out of the left lane. Like get out of the way.
I am actually surprised to hear that they still make Prius. Is that still a car?
Oh yeah.
That was the thing 20 years ago, right?
Yeah.
My
Yeah.
brother drives a
Hybrid.
Prius, or he used to, I guess. And it was, it got all the gas mileage, and it was like a sign of really being conscious about the environment. But I think there's all electric cars now. Are they all electric?
You're asking the wrong person about a Prius, man.
Yeah. You seem
All I
like
know is
somebody
they're
that.
in my way frequently. Like, I mean, if you're in a Prius or a minivan, and maybe I'm going to ruffle some feathers here, like, why would you even entertain the thought of being in the left lane? Like,
Yeah,
that
just
should
can't
not
take
be
it
your
easy.
default.
I don't know. Yeah, I'm not sure.
Yeah,
It's California. It's a weird place. So
yeah. I mean,
it's good to be
emails. I
back
mean,
then.
email us some feedback here if you want to join the revolution. I'm on board. Otherwise, I guess our basic housekeeping is downfracturepodcast at Gmail. We did get a couple emails we're going to go through here. I would also add, which I am bad at doing, we do have socials. We do have a YouTube channel, which most of the time I would say we're not incorporating a lot of visuals that add to the discussion, but sometimes you certainly
Yeah, I
could
mean
go and
that's
watch us.
that's news to me.
Yeah,
Yeah. So
I figured it would be.
um all right. Well, that's great. Glad we got all that.
I'm glad you're on board with what's been
Sweet.
going on for months now. Well, yeah, with the emails, we got a few. Some were kind of asking questions that maybe either I guess we didn't do a good enough job answering, or I guess probably the more realistic scenario is with the lack of structure to the podcast, which I find makes us more endearing. Maybe makes some of these topics a little more difficult to access or get a specific answer to. So we had some questions about TXA use and timing, and maybe even contraindications. I guess it was instruments and positioning of the proximal segment, tips and tidbits. Um, what else was there?
I think it just kind of nuts and bolts. I mean, we'll get to a couple of the email responses when it comes to that. I think those are all things that we've covered in terms of 2 grams TXA, right? And then
Yeah,
proximal segment positioning depends on who you're operating with.
yeah, I think the TXAU maybe do it a little different than me, probably because you're also a little quicker than I am. I generally, to answer the question, do a gram at the beginning, and usually I'm doing mandible first and double jaws. But for joint replacement, double jaws, do it at the very beginning. I mean, I guess for almost all my cases now, I do at least 1 gram. Like I've even done it for scopes, because some of those I convert to open, and sometimes you can get a little bleeder from putting the scope in, and so I've even started doing it for scopes, and I see your face, and you're thinking that I'm crazy.
No, no, I mean, I was just saying, I mean, I don't think there's any harm to it. I think it's used in orthopedics all the time. I think it's a good medication, minimizes the bruising. That shouldn't be overlooked, actually. I mean, if people look better, they're all bruised up and swollen, just kind of changes recovery. So making people look and feel as good as they can after surgery is a nice thing. So TXA is a good addition. So
So you're one usually for like a double jaw, one at the beginning, 1 gram at the beginning, and kind of one at closing.
that's how I do it in my office. At the hospital, I do it one when I start the maxilla. So
Yeah,
one at the beginning, one when I start the maxilla.
that's kind of what I do. My routine's gotten to be when I start the dissection for the maxilla, I ask for the second. Graham.
So
That's good. I'll do it. And then
what are we talking about today?
TMJR,
Growing patient?
yeah, I guess so.
Growing orthognathic surgery in a growing patient?
We can talk about that.
What do you
I think
think about this topic? What's
I don't know. I think when I was learning in dental school and training, this seemed like a bigger issue than I generally find it in practice. I mean, there's currently some important tidbits, but it was, I guess, from my orthodontic lectures and other things in dental school, it was kind of like, I don't know, maybe that was just my perception that it was emphasized in such a way that there was all this intricacy and detail and maybe complexity. Maybe that was a way of scaring people away from certain
sure?
professions or specialties or whatever. If you make it sound overly complex, you weed some people out or something. I don't know. I don't know. I mean, I definitely have this discussion. Patients definitely ask about it. It definitely impacts treatment decisions and treatment planning and timing. But I don't know. Maybe I'm making it oversimplistic. Are you finding that this is a
No, I'm the same way. I mean, I feel like this was an unknown question or a relatively unknown question in residency. Like, well, when's too young to do surgery, or how
yeah,
long do you wait for growth to be done? And are there times where maybe you do surgery before growth is done? Those sort of things seem to be uncertain. And as time goes on, I'm not sure if we have absolute answers to those sort of things. I think this question comes up most frequently in practical world of orthodontics, right? Because
probably.
orthodontics, there tends to be a couple of phases of ortho, like phase one and phase two. And from the perspective of someone who is going to need jaw surgery, like clearly class three or clearly class two or open bite or something, when do you intervene? Means when do you start orthodontics? And what they don't want is to have people in braces for 4 or 5 years. Did you have braces?
No, I did Invisalign as an adult.
You didn't have braces as a kid? You
Nope.
just grew up with just great chompers, huh?
I mean, I probably could have tolerated it, but I mean, I think that's a separate topic in general is like, do we all need orthodontics?
I mean,
Certainly
my
an
wife's like
American
you in
thing.
that she didn't have braces when she was younger either. She hasn't had them.
Nope.
My wife,
Yeah.
um, I'm the one bringing in the crooked teeth to my gene pool, where it's like half my kids are more than that are in braces now. But I went through a long period of ortho, and it was a hard time, right? Looking back on it, it was not fun to be in braces for a long time.
Wait, you had orthodontics
Yeah, I've been through a couple
and
rounds of ortho.
they felt your current giddy up is was an acceptable place to stay.
Hey man, I
That's the
grew up on
best
the
they could
Oregon
offer
coast. Cut
you,
me
you
some
know.
slack. Yeah, I mean, I as a side for personal thing, I have a mild maxillary hypoplasia, and I had a frostbite on a couple teeth, and the solutions to that at the time ended up removing a lower incisor, which kind of made the rest of it a little bit difficult. And so, anyway, I think that's partly why things drug on. Also, you know, my ability to show up to appointments when I was a teenager, all this typical stuff. But in the sitting of growing patient, when you're an orthodontist, I think what they don't want to do is have patients that are in 5 years of treatment. Like, I
Right.
don't think that's in anyone's business plan on the orthodontic side. And so when people come and see us for growing, it's very much the question of, hey, when do we put them in ortho? Right? Like that's really what the question I find in practice is really being asked here. Sometimes you meet people really early and they're wondering, can I do something to derail the need for jaw surgery, right? So if you see like the late elementary, middle schoolers that age versus, early high school. So I think that part is hard to appreciate as a resident just because you're not used to talking to orthodontists and interacting with those guys. But the real question of like when do they do ortho or when can you know, do TAD-based headgear or skeletal growth modification, those sort of things is commonly it. So what what do you tell people now for growing? Like your normal class two and class three. Like let's just hit the two most typical situations. Kid comes into your office with their parents. Hey, I was told I need jaw surgery. What are you considering?
Yeah, I mean, are you looking for a number or are you wanting insight into my conversations
Just
or
inside the combo. I mean,
yeah,
I've
I mean,
pitched. I haven't seen any clinic.
I do think it's an involved conversation because there's so much nuance and psychosocial aspect that comes into it, right? Like, I mean, if you're getting made fun of at school or online now that we have to worry about, like it's not so much, and this is where I do find that it comes in is I have that conversation of like, hey, you're here in my office. So like you're clearly interested in this. It doesn't mean you're going to do it. It doesn't mean the time's right, but like you've gotten to this point. And so you clearly have some interest in this. You clearly have some agenda towards a problem you want to solve. And I wouldn't think you would be here if that weren't the case. And so we generally have that discussion of more for class threes than class twos. Um, that's where I think it's a little more I get a little more uneasy about it or have a more, hey, that you might need more treatment kind of scenario. But hey, if this is bothering you, these are the impressionable years of your life. We can always plan in a little bit of, overcorrection, so to speak. Okay, maybe you are going to grow. So maybe we do a little bit of this or that to compensate for that potential, or we work with the orthodontist to say, hey, where would we maybe get in trouble if there were continued growth and we overcorrect or overcompensate a little bit in those ways? But I always warn them, hey, if you're still growing, you might need more treatment and you have to kind of weigh the pros and cons and do what feels best for yourself. Because I mean, some of these kids are just brutal, man. Like I wouldn't want to be getting made fun of through my
Yeah, no,
team.
I mean it's different with the whole internet and everything, but I mean I remember learning that from I think it was Myron Tucker um on the functional reasons to intervene. And the, the honest discussion about getting made fun of, I think it is something to bring up, and it's one that's hard to broach, right?
Right.
I think the easier ones that come up have to do with sleep apnea or condylar resorption, those sort of things, right? Like we won't jump into the condyle stuff, but when it comes to sleep, that's a good reason to intervene. Really big functional concerns. Because if they're having a really hard time and they're 12, 14, 15, independent of the risk of needing another surgery, it should be really discussed how bad off they are. Because,
Mhm.
like you're saying at school, if they're really getting harassed, I mean, making it better makes that has good value, right? Like that's a very useful thing. And because it's the big functional concerns, airway, social stuff, mobility, those sort of things. The more typical group is, they have a bite issue that they're being followed by their orthodontist about, and when do they do that? The standard rules of thumb for a couple years after the monthly cycle starts for women, for guys, kind of late teenage years. When it comes to class two, have you ever met someone who overgrew their mandibular advancement? Like,
Not
have
that
you?
I can recall. I might have, but I can't recall it, or not that I attributed it to growth. I mean, you meet people who like maybe later in their adult years they would say, I used to have an overbite and now I'm more edge to edge. Or I mean, I have scenarios arise.
Don't you think that's
Um,
like dental wear? I mean,
yeah, I mean that's what I'm thinking. That's what I'm getting at is I don't know that I would attribute it to growth because it's like they'll say and I was in that position until I was 35. And then I noticed a change, or I was 40. And it's like, well, I don't think that's growth, right? I mean, I guess you can't rule it out, but that would be an unlikely scenario. It would be joint issues, dental changes, appliances or other positioning habits. I mean, you could make a list, and growth would not be at the top of that list for me in that scenario.
yeah, because I mean, what I learned on this stuff, and this is how I practice still, is just low angle class two, definitely fine to get going while they're growing. High angle, really, you're just worried about condyles, and the condyle concern is always a concern, right? Like it's a concern in growing patients, it's a concern in non-growing.
Well, it's a concern whether you operate on them at any point or not, even if you don't operate on them. I mean, like that concern doesn't go away by operating early, late, or not at all.
Yeah, so I mean, the condyles being stable before you go put people through jaw surgery, and particularly mandibular advancement, is still a rule independent of the growing business, right? Like the resorption of the mandible, I don't think is maxillary growth. You know what I mean? I
Yeah.
guess so. I consider that more like a separate issue. But growth in class two, it seems like it's the right approach, particularly if there's functional concerns. Class 3 waiting on it because there's it. I don't know about you, but if they're not bad, most people don't seem to be too bugged by their underbite. Like they're just, it's not a typical thing that I meet early teenagers that are really that bothered by the situation.
Hmm. I feel like I
And
have met some. I mean, I can think of some.
can you?
Usually it's when it's more so when it's accompanied by asymmetry.
Oh yeah.
But yeah, but when you have some of that underbite, I've had some, again, kids are mean.
Let me
Uh,
ask you, in that subgroup, where you're considering asymmetric condylar growth, so mandibular asymmetry in the growing patient, do you monitor them with bone scans? What do you do?
yeah, I think we've talked about this before, haven't we? I mean, I guess that was
I don't know about
more
the
in,
growing kid, like a 16-year-old, let's say
yeah,
lady, should be done growing, mandibular asymmetry. What do you do? Wait?
I think you kind of treat them the same. Oh, I think, well, I don't ever think if you can notice on your imaging and exam that there's asymmetry and it appears to be in the condyle, like if it appears to be some type of potential pathology, having a baseline bone scan, I don't think would ever be a bad idea. Um, I just don't know that it would affect my management too much at that point. I would probably still treat them the same. What
Yeah, I
about
don't know.
you?
I put the class 3 and the asymmetric class 3 people. If they don't bug them, I kind of like waiting. I mean, and especially with Invisalign and retention in that way, it's not an end of the world if they just wait until they get older. Because I mean, I do think the asymmetric patient can continue to grow at that age, and class 3 obviously can. And so, um, in the absence of significant functional or social pressures, I think waiting on those, the class 3 patients or the asymmetric class 3s is reasonable, right? So just giving it time.
I don't think it's wrong. I mean, I don't think it's right or wrong. I mean, I think it's the same story of how much is this bugging you from a functional, from an aesthetic, from a psychosocial standpoint, and
Good.
here's the risk and understand that this may not be done, and what does that mean to you?
Yeah, because the other things that come up are, people moving, insurance concerns, just like very life, like real life stuff, like family changes with like divorces and everything. Um, that social stuff is a real factor in how this all plays out. And in the group of kids that are in middle school and high school, trying to figure out the right balance of things. Class 3, I'm always partial to waiting though. I, I just don't see any harm in waiting. And the patients that have had jaw surgery in the past, I have seen people overgrow a class 3, like
Yeah.
come back in their 20s and then they're edge to edge or even reverse overjet again.
Do you find that most, I mean, in that experience, are they within the realm of orthodontic treatment alone, or do you feel like they require further jaw surgery?
Yeah, no, I mean, I think there's a revision subgroup that's that. I don't think that's all that common because it's a little bit unclear if it was a healing difficulty issue with the original surgery, but people give good histories and I believe it. I've definitely met people that continue to grow in class 3. So I think my general answer when it comes to this, and I think what I would do with my own kids is, absent any significant functional or social issues, I think surgery is reasonable as long as they're not class 3 or asymmetric class 3, right?
How long do you wait? How do you make that determination?
Because that's the other part of it. That's what I was going to ask you in terms of the condylar asymmetry part.
Because you got to do it at
I don't
some
think I've
point.
ever
I mean,
successfully waited. Um, I've had people say, "Yeah, let's wait," and then we come in. It's like, when do I come back? And I don't have a great answer for that, honestly.
right.
I'll see you in a year or two. Let's just put ortho on hold and come back in a few years. The waiting place is not cool. Isn't that a Dr. Seuss book? Is that the places you'll go? Do you remember that book?
Wait, was that Shel Silverstein?
The places you go, I thought was Dr. Seuss, and there's the waiting place.
Let me look
Anyway,
it
the
up. Now it's
waiting
going to
place
bother
in
me.
terms of ortho and jaw surgery is not a fun place to be.
Oh, the
Are you looking
places
it
you
up right
go.
now?
Yeah, I am. Yeah, the places you'll go is Dr. Seuss. Would you say the other one, the waiting place?
Well, that's what in that story, it's they talk about, like I guess the places you'll go, like the things that you'll do in the future, and then
Oh
you'll
yeah,
intermittently hit this pause and you get stuck in these things. And in orthodontics, just being stuck and waiting for things is not where you want to put people. So
right.
I hadn't considered that Dr. Seuss would come into our discussion here, but I guess it's pretty applicable.
Right. I mean, I always like to have these little tidbits. Does it count as an old man saying?
Kind of.
I mean, yeah, I mean that's part of the question, and that's part of my discussion with them is, and I frequently we tell the patient, I don't know that I or we as a profession have the right answer to this scenario, and I frequently try to make it a shared responsibility,
Yeah.
meaning I don't know, you could still be growing. You need to decide, you as the person paying for this, undergoing this, you need to decide which is a more tenable solution to you or situation to you. Is having surgery and outgrowing it and maybe needing more orthodontics and or surgery, is that more in order to get going sooner? Is that a more ideal path for you, or is waiting to do everything you possibly can to ensure you only go through this once? Which of those, if you had to say, is a more desirable path, which would you choose? And then I think when we have that answer, we make the decision based off that as a unit. And then I feel the shared responsibility also hopefully leads to shared blame if any were to come about. And
Well, it's just
how I
I,
approach.
I would say like in the practical nature of life, ladies 2 years after the cycle starts, that puts them what, like 16, 15,
You
16,
do you do 2 years?
roughly 2 years. I mean, as a
I usually
ballpark.
do 2.5 to 3.
But I mean, it puts them in high school, right? Like they have braces in high school and they get through surgery in high school.
Not necessarily, man. Definitely some precocious puberty this day
Oh,
and
on
age.
the front, but I mean, in on average, I think that puts girls generally in high school for going through all this. For guys, it's a little bit different animal, right? So, just because of the later growth and it starts drifting into military, drifts into, college, just, the next stage after high school, people really disperse, right? And, um, I think that should be considered in the overall picture of things, right?
I
Because you don't want
mean,
this to like slow their, whatever transfer to Cambridge or,
right.
whatever kids are doing these days.
And you touched on the cost and the insurance aspect of that too. Generally patients can stay on their patient or their parents' insurance till like 26 if there's not other insurance involved or whatever. Maybe that's changed, um, but the other aspect of it is who's paying for it. Like,
Yeah.
and that's a weird topic. Like, if I get a good rapport with the family and they start saying things like, "Well, even if we wait, son or daughter, we'll still, mom and dad will still pay for this." Then I'll make the joke of, wink, wink, nudge, nudge. You might want to do this while mom and dad are still paying for it. But that's a very real reality that's sometimes difficult to bring up of like, hey, you're 17 and I don't know your situation. When you're 18, you may be cut off for all I know. Or like you said, you may join the military or the Peace Corps, or you may become a wizard. Like who knows what's going to happen? Like
Yeah, I think
it's
wizard
real
schools, they're
things
pretty lenient for time off for recovery.
most of the time.
No, but I mean, I I don't hate the idea, especially with Invisalign these days, for class 3 patients to be set up basically for surgery, and then you just do surgery, right? Because what they really don't want to do is then start orthodontics once you're done growing, right? Because I mean, ideally, you start ortho just at the tail end of growth, so you get through this efficiently as possible, rather than wait till growth is done, start braces, then do surgery
Surgery
later, that
first.
nature.
Surgery first.
Yeah, exactly. So, I mean, but that isn't really surgery first. It's like phase one ortho is done as an older kid, like
Maybe. Yeah.
I don't know. I
So
think
yeah,
that's
I'm sorry, go ahead.
no, I was just gonna say the Invisalign business and kind of setting people up to where really they're waiting on just surgery is a good middle ground, right?
Yeah, I mean, I agree with you. And I think to put a bow on this part of the topic, class two, I don't worry about it as much. You definitely have to weigh in the condylar component and make sure that that's stable, as you said. I think that's a valuable piece that sometimes gets overlooked. Class three, you feel like you wait a little longer. I just have that discussion and I really kind of leave it up to them. Um, but I definitely tell them there's very much the potential for latent growth. And these are what our textbooks say, but life's not a textbook. You could outgrow beyond years beyond what we think, or you could already be done and we don't know. So that's how, I mean, that's kind of how I go about it. Where else does this come into play? Because the other one that I think of is in the transverse and the maxilla.
Yeah, I mean, max their issues like VME or hypoplasia or transverse issues.
So how are you going about that?
Um, I mean, in that world, it's more like, where are they at from a dental standpoint, right? Like, how many teeth have really erupted? What's the overall picture here of how bad off they are? I mean, if it's a full Brody bite, that's going to be different than, let's say, bilateral posterior cross bite. And in the growing patient, I mean, expansion's very doable, right? Like non-surgical expansion. I mean, non-surgical expansion, TAD-based expansion, that sort of thing is amenable to that patient population. So I would say a lot of maxillary issues are amenable to that. I would say the vertical hypoplasia ones is tricky, right? So that's tricky because bringing them down and kind of keeping them there and allowing it to heal. Um, but luckily, it's not that common of a patient, right? Like the 14 or 15-year-old with vertical maxillary hypoplasia. What do you think?
Yeah, I mean, the main point where it comes into I see it is with the transverse and can we expand without surgery? And I would say, maybe this is probably we've touched on it, but another topic to get into, maybe from an orthodontic perspective, because there's just so much new information or misinformation, disinformation. I think trying to sort out what's real in the treatment of the transverse dimension in 2025 is a little bit challenging because it depends on who you ask, um, and what their experience is. Like, do we need surgery even at 30? If you ask some people, they're going to tell you no.
Well, but I mean, I think in teenagers, because it isn't very controversial in middle schoolers, right?
No, no,
Like
no. I
expansion
mean,
and
until about what? Until growth stopped, really, right? I mean, that's kind of where we're getting at is if you feel like there's still growth, then you should still be able to get.
or if they're around the time of growth. I mean, I still think maxillary expansion. Maybe I'm wrong in understanding that from the orthodontic side, but I mean, conceptually, the idea of expanding when sutures have just recently closed seems more plausible to me than, let's say, a 6-year-old person, right?
Right.
So I mean, I think the growing patient is amenable to expansion. But I mean, largely in my world, that's done without surgical assistance. So that's managed by ortho. So
Yeah, occasionally put in TADs or something like that, or help with that. I've done, but yeah, mostly that doesn't come our way
yeah, I mean,
now.
the patients of like the early teen, mid-teen, they're great patients. They just heal right up. Those guys just don't know anything other than to heal. They can be a little bit squirrely in terms of following instructions, but
Yep.
good parents will keep an eye on them. And the big benefit of going through surgery at that time is it's such a smaller bump in the road. Like they just bounce back. It really is. So um, I like that group of patients in terms of predictability of healing and neurosensory recovery and just kind of the normal troubles you run into seem to be less common in the younger person. So it's kind of an argument for it, right?
In some ways, and then but the other, you kind of touched on it again, but the trade-off is, are they mentally capable of undergoing a major elective surgery?
Yeah, I mean, I think we have that at all age groups.
Oh yeah, no doubt.
So
I mean, there's some kids you meet that you're like, man, I don't know that you can go through wisdom tooth removal right now. Like you just don't quite seem there. Um,
yeah, yeah, and I mean, I think you're just speaking to more factors in terms of making the decision clinically on these. But I think generally what people are worried about is having another surgery. And so jumping in too soon on surgery is, generally a bad idea. But if there's good functional reasons for it, I like surgery early. So
yeah, I mean, I can't remember who it was that used to say to me in residency, you're not going to ever regret waiting. Like you're never going to look back and say, oh, I wish I had done this earlier from a surgery standpoint and a need for doing further surgery. Certainly you could look back and say, well, they were done growing, whoops, or I didn't need to wait that long. But um, I don't know. It's kind of an interesting perspective, and I think you'd get different answers from like if we had 10 surgeons and 10 orthodontists on here, I think you'd get a lot of different answers.
yeah, I mean, the the interesting one, I think, when it comes to this subgroup is the people who have really severe class threes. Is it worthwhile putting him through headgear or TAD based growth modification? I mean, I know the argument, and I've been taught this, that you can have treatment fatigue, and there's good reason to just kind of hold off and let them grow. Um, mention surgery is down the road, but just wait, because if you try all these other things, they can get burned out. I mean, I know from a personal experience, I got burned out with ortho. I mean, by the time I was done with braces, I was very accepting of imperfection, and I was like, look, man, I don't care. I got other things to do. And so I
Well,
think
financial fatigue,
sure.
you can't put them through thousands and thousands of dollars of treatment and then turn around and say, hey, you need to pay thousands more. It's not always a
Did,
reasonable solution either.
did you were you where were you like in training? Were you in practice when the de Klerk mini plates were in vogue?
Oh, the TAD-based plates to try to, yeah, I
Yeah,
mean,
the four plates, Hugo de Klerk, good paper. He had
yeah,
good outcomes.
reported, yeah. I mean, I remember someone coming and talking to us at UW at one of the, I think it was the grand rounds. That would have meant I was either in training towards the end or newly out in practice.
Got
But
it.
I never really did it. I think I placed a few, but I don't think I ever really actively had that as a part of my practice. Did you?
I mean, I feel like I was either a fellow or newly out after fellow was when all of that was going on. And I lived the life of seeing what the trouble was, which is if one of the plates goes down, then the whole system goes down. And I don't know about you, but the problem with TADs in my practice still is the likelihood that one of them gets infected or loosens or irritates their cheek or something like that. And so you need 4 out of 4 success. And um you also need patient compliance, right? And that combo um made it unpredictable, and no one liked putting people through surgery and a whole second surgery to take them out, and they still have the problem, right? And then you're doing jaw surgery because um, I did. My impression of why that hasn't caught on as much in America is just the largely practical nature of it for that those issues. Because do you get consoles for that anymore?
No.
Yeah, I
And I'm
mean
trying
it's
to remember
relatively
because
quick.
it was like zygomaticomaxillary buttress plates, right?
Yeah, and then you have plates around the canines,
Yeah.
the mandible. You'd wait for the canines to be out of the way, so you'd want them to be old enough, maybe 11, 12.
Yeah, I'm
And I
trying
mean
to
it that literature is solid. It supports that technique. And conceptually, it makes sense too. I mean, superimposed data shows you get maxillary growth. It isn't just like a headgear effect where you limit mandibular growth. So it's just it's hard to get those in and have them in and have people use them and be successful with the whole thing. So I think the treatment fatigue is real and burning people out. Um, got to be aware of that. So
for sure. Do you think the maxilla grows after a Lafort?
does the maxilla grow after Lafort? I don't know. Probably not.
Yeah.
I'd have a
That
hard
was a
time.
tradition. That was a traditional thought, right? Or like I think that's
How
what we're
would it
taught
grow?
is once you cut it, it can't grow anymore, but the mandible can. Like that's
Yeah.
how I was taught at least. But in practice, I never look at that as much as I look at the mandible. I guess I just kind of always operated that as if that were the case and hadn't really looked at it.
Yeah. I mean, maybe it just has to do with the condyle and that sort of thing. But yeah, I mean, I think the growing patient is a very clinical discussion more so than an academic one, because I don't know, reading that old literature, I was always not old, but like, 70s, 80s type of jaw surgery literature when they were doing high volume stuff and producing a lot of the information that we all kind of accept as known information. Um, it's not all that clear from that those papers. So it's good stuff to look at if residents have study clubs and that sort of thing. It's all
Sure.
interesting, but um,
Do you find this to be surgeon generationally different? Like I can vividly remember multiple times throughout my career a patient's coming for second opinions and them being very much like, and it was almost always an older surgeon. Doesn't mean anyone's right, wrong, good, bad. And it seems like the older generation was very rigid in when they would operate on
Sure.
patients, more so than I think subsequent generations. Do you find that to be true in your experience, or can you speak to that?
Yeah, no, I think that's true, but that probably just comes with practice, right? Like, I mean, I think that comes with experience rather than a generational thing.
Maybe.
Because I don't know, I feel like I'm probably more rigid than I used to be in terms of
Hmm.
practice, following some rules and sticking to some thresholds of when to do things just based off of living the life of looking after patients, right? Um, so I could imagine, 40 years in practice having different opinions about these sort of things. And so I don't know. I in fellowship at least and talking to people, it seems that most people are comfortable with putting people through surgery, even if they're still growing, with the exception of class 3 or asymmetric patients.
Right.
Um, and
And
I mean,
that's what I'm kind of speaking of is I can vividly recount in two different practice locations people coming and saying, Dr. So and so absolutely told me he or she would not operate on me until I was, 19, 20, 21 for boys or 17, 18, 19 for females. And I'm like, I mean, I understand where maybe that opinion's coming from, but it just seems a little bit too much. I don't know.
yeah, I mean, it's hard to say. So, but I think I don't know. I don't have too much else in this subgroup. I feel like we chose a shorter topic because we didn't have as much time today. But it was good to talk this one out.
Yeah. Well, yeah, that was another Down Fracture podcast for talking jaws. Email downfracturepodcast@gmail.com. We, as you heard at the beginning, do read and pay attention and try to respond to the emails. And yes, which was news to Sam and maybe to some of you, we do have a YouTube channel where you can actually watch us talk about these things. I don't know why you would want to, and there was absolutely no visual benefit to today's podcast, but
Yeah, I
should
mean,
you like that medium, you can go to it.
yeah, you have a screen, and I was waiting for something to happen with it, but it just stayed the same here. So, you'll be disappointed, I think, if you watch this episode rather than just listen to it.
Yeah,
Um, but yeah, we're back on normal time next week. Is that right?
hopefully we'll figure it out. All
Great.
right. Well, see you next time.
All right. Good talking with you.